Great. Good evening, everyone, and a very, very warm welcome to this session, safe session of February 2026. And today, especially, thank you everyone for coming in large numbers. That's a record in itself. Fantastic. So, before any delay, let me share a short presentation so that I can take you to today's current session. So, as usual, many of you are return attendees. So, safe is safety awareness for excellence. So, we do these sessions, and these are held by our Annie Patient Safety Fellows. So, before that, we are going to play the Annie anthem, and I would request all of you to stand. You can put the video.
Ma'am, it is there is no sound, ma'am.
Voice is not coming now. Sound is not there, ma'am.
We are the voice, the hands that care, guardians of hope, always there. With wisdom and courage, we stand tall, answering the call, serving all. In every moment, through joy and strife, we lead with purpose, we honor life, building the future with knowledge and grace, transforming healthcare in every space. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. Together we rise, united we lead, planting the seeds for a brighter tomorrow. Together we rise, united we lead, planting the seeds for a brighter tomorrow. ANEI, nurses make the difference to humanity, shaping the future with strength and unity. Passion to action, our guiding light. For every life, we fight the fight, upholding safety with hearts so true. We are ANEI, proud in all we do. We are ANEI, proud in all we do.
Thank you everyone for being there for the Annie anthem, and we are really proud of that. So, as I mentioned earlier, this is brought to you by Annie Patient Safety Fellows. This is the fellowship program that Annie organizes in collaboration with the Patient Safety Movement Foundation USA. May I ask everyone to be, muted, please? Yeah, thank you. The the intention is that we have a whole calendar starting from January 2026, and every topic that we do is contributing to improve patient safety. So this year, all the topics are primarily taken by the cohort of 2025. So that is one of the things that every fellow who joins the fellowship has to do. So there are many different topics that are brought to you. Last month, we understood the high risk situations, in the WHO framework. So we talked about all the safety aspect for patient safety. Now, this time we are going to have Ms. Swarupa Veluru, who is the ANI Patient Safety Fellow from 2025 to 2027, and along with her mentor, Dr. Shubhangi Jadhav. She's from 2024 to 2026. So the topic is going to be safe prescription, safe administration, safe monitoring, safe documentation. And I'm sure that this session is going to be very, very practical oriented one. No gyan part. It's all understanding the how of doing things and why we should be doing that. So in March, we would have medication reconciliation as a topic from WHO 23 to 24 update. That will be done by Ms. Chandrani Chakrabarti. She is also cohort 5, Annie Patient Safety Fellow. She'll be accompanied by her mentor. So with that, thank you everyone for being in such huge number before the session starts, and a very very special invitation to all of you to Adicon 2026 to be held at Taj Land Ends, Bandra, Mumbai. The Anicon will be hosted by the Maharashtra chapter, and we are very excited. So keep watching out for the informations that will be coming. We'll be soon releasing information for registrations and competitions, everything coming your way latest by next week for sure. So very warm welcome to Mumbai. So over to Shubhangi, who happens to be from Maharashtra chapter. So the mentor for Swarupa. So over to you, Shubhangi. I'll be
Yes, yes.
here, and then Swarupa can take on the session, and we will please remain interactive with this session because this session is going to be feedback. We have to talk to each other, so let's learn from each other. Over to you, Shubhangi. Thank you very much, and a very warm welcome to Swarupa and Shubhangi, and all the very best.
Thank you. Thank you so much, ma'am. Swarupa, if you can share the PPT. So good evening all. Uh, I'm really pleased. So today in huge number, all are present. Thank you so much. Thank you to Almighty God, and thank you very, very much for this opportunity. To special thanks to my mentor, Madam Thankam. I'm really blessed to having one of the best awesome mentor. Thank you so much, Thankam Madam. Always grateful to you for this opportunity. So today we are going to this session is going to be very, very interesting. I will request everyone to pay all your attention, concentration till the end of the session, so that you will really enjoy the session. Because we have just seen the anthem. Annie has its catchline, passion to action. So we always, Madam Thankam, make sure that all the presentation done by all the safe fellows, patient safety fellows, that they stick to the this catchline, passion to action. So it is going to be a action oriented. So today we are going to talk about next slide, Swarupa. So this is safe prescribe, safe administration, and safe monitoring and safe documentation. This is when we say about medication, it starts all the way from prescription till the monitoring. So today, this we are going to this topic we are going to talk about Miss Swarupa. I will just introduce Miss Swarupa Velluru. She has got a huge experience of total 24 years of a clinical experience, especially in operation theater. She had done her GNM from 2002 to 2005. After that, she did her post basic BSc nursing from 2010 to 2013, and 2019 to 20 she had done her MBA in hospital management. She had worked with various hospitals like Narayan Hrudayalaya. She has got all different hospital experience or corporate hospital. This Columbia Asia Hospital, Ramaiah Hospital, then Nova Specialty, Aster CMI, Sagar Hospital, Fortis Hospital, then BGS Glen Eagles, and currently she is working in Apollo Hospital, Jubilee Hills, which is Hyderabad, Telangana, as a OT manager. So, today she is going to discuss all details about the safe prescription, safe administration, safe monitoring and documentation. Because nurses are all being connected with all these stages. There are various stages of medication administration, so nurses are always concerned. You can see the incident, especially in Indian scenario, that this, especially in intensive care unit, there are a lot of chances of medication administration error. These errors, why? Because ICU is a very complex area, where there are a lot of stress, PPPP, and demand, send this investigation, where are the reports, start this thing. So all these things are because very complex environment ICU. So in this pie chart, you can observe, you can see this, you can see administration errors are the maximum errors, and the nurses are only concerned with medication administration. So that is what we should be very, very keen, and because we are very significant with very like there are chances of doing the medication administration, especially during the
అరే ఆయనతో అంత ఫోన్
administration phase.
మాట్లాడరా మీ బాబాయ్ తోటి ఒకసారి
Please keep yourself mute. Next slide, Swarupa. So these are the various medication error. So there are a lot of kinds of error. We think that this is the only administration. That means giving the injection IV or IM. So that, but it has got different types of minute errors that can have a significant impact, can harm the patient. So prescribing error itself, yes, nurses must know what doctors are prescribing. So that can be a wrong drug, wrong dose or a wrong frequency, that can be there. There can be omission errors. Omission errors can be like, some of the hospital, the patient's relative has to get the medications and they have their own issues. They have manpower shortage. They have to go for the blood collection, blood report collection, or many a times they don't get the medication on time. So in that case, there are chances that that dose may get omitted. So also nurses are overloaded with the works. So there are chances of omission errors. Then wrong time, same thing. The same example I mentioned, that when patients' relatives are unable to give the medication on time, in that case also sometimes there are chances that the medication will not go on time, because there are medication that are being advised for what? QID, TDS, for what? To maintain the therapeutic levels of the drugs. That is the purpose. When we don't give on time, definitely the purpose will not be achieved. So there are improper dose errors, wrong dosage form errors, wrong drug preparations. So there are a lot of examples. There are incompatibility of the drugs with certain diluents. So there can be a wrong drug preparation, then wrong administration technique errors. It can be a IV or wrong methods. I have seen a hospital where a nurse was advised to give coconut water through rice tube, and that nurse took the coconut water and she administered through IV, and that patient dead actually. So this is very significant. Long back it is. Then deteriorated drug errors can be there. Then very important monitoring and documentation errors. See, nurses monitoring, nurses documentation plays a very, 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 very important role, especially in the legal safety. The correct documentation can save nurses, like in any time it can be prevented from nurses to cancel their licenses, or they can go behind bars because of the we can save from going to the prison. So that is what. So and monitoring is very, very important, because we are administering the drug, so we must monitor what are its effects, whether it is proper or no. Next. Next, Swarupa, next slide.
Yes,
Swarupa,
yes, ma'am. It's not moving. I think that's issue.
What
it's not
happened?
moving.
Hello, Swarupa.
Yes, ma'am. It's not getting moved now.
Do you want
Did
me
you
to share?
stop?
Otherwise, you stop sharing. I will share.
Okay.
Are you sharing?
Yes, yes, ma'am. I'm sharing.
Apologies to the audience for
Uh,
this
really sorry for
technical
this.
glitch. No
Ma'am,
worries.
is it visible, ma'am?
Yes, yes. Put it on the slideshow, please.
Yes, ma'am. Okay, ma'am.
Yeah, good.
So we are talking about, so medication, there are various stages of medication process where it goes all the way from prescription stage, transcribing stage, dispensing stage, administration stage, and monitoring stage. So all these, during this, what will be the errors that is going to happen? So we are all concerned, being nurses, we are concerned and connected with all these stages. So this session is going to be a very impactful for all the nurses, so that we will understand what is our role and how we can prevent. So over to you, Swarupa, now.
Thank you, ma'am, for the given opportunity. Good evening, everyone. Thank you for being here. So today I would like to discuss about, as already mentioned, about the stages of the different from medications, from the prescribing to the monitoring. Here there is a slide which is talking about the prescribing errors. So what is the role of nurses? Can you read this? Neither can we. So looking at this description is very illegible. And what is the drug? We are not able to found. And the dose of the drug is not clear. So first of all, what it is written is not clear. So in this scenario, again, we have to recheck with the concerned doctor to write the legible prescriptions. And look at the second picture, which shows that it is clearly, again, it is shows that desorption 5 mg IV and now. So this is also not clear. And here it is written desorption point 0.5 mg. So always use leading zeros for decimal points. The order should have read. And can anybody guess that the down one, which is talks about injection KCL 40 mg over 4 hours? Here again, clear written instructions is not written. Instead of injection, it is written IN. Instead of 40 MEQs, it is written 40 mg. And there is no dilution and it is written over 4 hours. So everywhere it is, there is no clear instructions which is written by the concerned doctor. So always, as the nurses, we need to be empowered to cross question and always ask them to write it in a legible handwriting of detailed prescription for the medications.
Swarupa, I'll just hold on for a second. If we go back,
Yes,
I
ma'am.
would like to ask the audience, especially the KCL order. So, what should a nurse do if she or he sees such an order? Will they carry it out or what will they do? Anyone in the audience, please unmute. You can answer. Question is, will you carry this order out?
We will not
No,
carry, ma'am.
ma'am,
We
we
will
will
ask
not
to
carry.
doctor to rewrite.
Good evening, ma'am. This order is incorrect, so we will not be carrying it out. We need to make the correction first, and then only we can carry it out. This
Fantastic.
is an high alert medication, so we need to double check before doing so.
So, thank you for the answer. It is not only for high alert medication, any medication which does not have all the components of prescription. the right, all the R's, no, like the root, the abbreviation should be correct, the dose should be mentioned. And in this KCL, not only injection, not only MCQ is missing, it is also not written what is the dilution. And this is an error that I have seen multiple times. So the dilution also should be written, otherwise a new nurse might just give a 40 milliequivalent KCL injection, KCL 40 milliequivalent over 4 hours. If that is written, somebody might give it neat KCL, which is not at all correct, right? Just just to reiterate, I'm sure that all of us know that we just have to tell our nurses stop carrying orders. When you're in doubt, just stop. That's it. Thank you, Swaruba. Please carry on.
Thank you for participation. Keep participation. Let the session be very interactive. There will be a lot of questions. So continue, Swarupa.
To talk about the next task is top 8 prescription errors where the nurses must catch. So here again it is easy to catch these 8 errors, which is illegible handwriting, wrong drug due to similar name, missing route or frequency, missing weight or patient parameters, wrong abbreviations, confusing decimal placement, unclear verbal order, missing allergy documentation. When we look at each parameter, illegible handwriting talks about example is injection doxy
Oi,
100 IV cure.
net ಇದೆ
Here the nurse misinterpreted as doxycycline 1000 mg IV cure.
ರಿಚಾರ್ಜ್ ಮಾಡ್ಕೊಳ ಕ್ಯಾಶ್ ಕೊಡ್ತೀನಿ
Please make mute. Clarify illegible
ಅದ್ರ
prescription.
ಪಾಸ್ ಏನಾಗೋ ಇನ್ನು ನರ್ಸಿಂಗ್ ಗ್ರೂಪ್
When we look at the wrong drug due to similar name, here example is order written is metoprolol 25 mg POOD. Nurse dispensed metoclopramide 10 mg. So always we have to watch for larger drugs. Missing route or frequency, order written as ceftriaxone 1 gram, no route and no frequency which is written. Nurse assumed IV once daily, confusion and delayed therapy. So always we have to look for verify route and frequency. Missing weight or patient parameter. So the order is written as a gentamicin 4 mg IV, which is no weight recorded, should be weight based. It is pediatric dose. A patient received overdose, elevated creatinine levels. So here again we have to check for weight and parameters whether it is really pediatric or an adult dose. And look at the wrong abbreviation which is given. Order is written is OD, so no weight recorded. Never miss it is again avoid weight and parameters. Confusing decimal placements. Physician wrote 0.5 mg and 5 mg. Drug administered at 10 into dose. So here again we have to look for no trailing zero, use leading zeros. Unclear verbal orders. During shift change, physician verbally ordered, give dilantin first thing. So ask for readback. And always we have to make sure that always verbal orders recheck with the over telephonic conversation. And we have to ensure the same documentation should be happen within 24 hours of the drug which is ordered. And missing allergy documentations, the order written, prescribed penicillin, patient has recorded allergy, always check for allergies first. So preventing prescription errors, if unclear or missing details, stop and clarify, fully review allergies and patient parameters, confirm correct drug dose, route and frequency. So these are the things where we can empower the nurses to top 8 prescription errors nurses must catch and prevent the errors will happen. And when we look at the abbreviations of the do not use dose and unit abbreviations, which is given as a basic where the student and the freshers and junior nurses can easily understand by the symbols and the clarity what should be in correct form. So here again, few examples which is showing do not use is, new is, why unsafe is can be read as 0 or 4. So write instead of units. And then international units, which is IU. So write always international units. UG, it is again, it is micrograms. And SE bar SQ, it is at. And at the rate is always greater than or less than. And again, few more frequency abbreviations. It is QD, read as QID daily, and QOD, read as QD or QID every other day, and HS confused with fast strength at bedtime. And few more examples. It is about decimal expressions. Here again, which is written 0.5 mg. So it should be written as a 0.5 mg, and 5.0 mg, which is supposed to be just 5 mg. So rule is always use leading zeros, never use trailing zeros. Do not use drug name shortcut. Example, write full name. It is morphine sulfate and magnesium sulfate and methotrexate, hydrochlorothiazide, right, clarify. So here they have given all the shortcuts because all are not thorough with the formulas, as all are not into medical terminology. So always use the full names. Additional high risk practices to avoid: verbal orders without documentation, unclear handwriting, overwriting corrections, unapproved abbreviations, drug name without strength, dose without route. So these are the things where we can prevent easily by the freshers. And always they have an opportunity to ask the seniors and the concerned in charges on that department. There is an example for preventing administration errors. Here again, one example, which is right patient. Here we have two scenarios, bed number 13, bed number 13. So one is Mr. Rajesh Kumar have a type 2 diabetes. Here it is, the order is written injection insulin 8 units subcutaneous before breakfast. When we look at the bed number 13, here it is a patient diagnosed with a COPD. The prescription is written nebulization and IV antibiotics, no insulin prescribed. So what happened here? The nurse prepared the insulin for bed number 12, entered the bay and administered insulin to the patient in bed number 13. Nurse did not check wristband, asked patient to state full name, verify with medication chart at bedside. Patient in bed number 13 assumed injection was part of treatment and did not question it. So always here, IPSU one error, we have to ensure that before going to the bed, so whether it is a correct patient or not, what is the treatment along with the file, we have to ensure and go to the bed and cross check what kind of treatment prescription is written clearly. What could have prevented this? So always we have to ensure. Can anybody answer what could have prevented this?
Please unmute and interact. What could have prevented this? Swarupa already
We have to
mentioned.
cross check with the patient wristband.
No, you should have known the diagnosis of the patient, why the patient is getting insulin.
So
We should
I think
always
all
cross check with
answers
the
are
wristband and hospital ID that the 5 hours of the administration should have been followed.
I yes.
Ma'am,
The
I
staff must have.
would add one more thing. Here, if we could add the patient and family to be involvement is more important. Both the patients are conscious if the medication administration just before that, sir, Mr. Ramesh Kumar, I am going to give you insulin. Then at least that time patient also will be knowing, yeah, I am not the right patient. I am not getting the insulin. Like the involvement of patient family is also can prevent
Okay,
some.
all points are correct. I just want to reiterate one thing. This is one practice that we are not doing. So I want to repeat that is never call the patient by his name when you're going to do such procedures. It is always better to ask the patient, can you please state your name? If the patient is conscious. After that, somebody already put in the message that the medication administration record should be taken to the bedside. Fantastic. Then ask the patient to state the name and look at the details on the MAR, that is medication administration record, compare it with the ID band. This is how IPSG 1 gets implemented wherever it is. So many times now we are very quick in saying, do IPSG 1, identify patients correctly, but seldom we concentrate to say that we should ask the patient to state his or her name. Rest all the things are also important. All of you told is very correct, but I would really request only one takeaway. Train the nurses to ask the patient to state the name, and if they cannot, then the ID band. The matching of these two, UHID and patient ID, with the MAR, with that of the ID band, it should be like this. That activity should happen. If that's not happening, these things can happen because they are similar sounding names. Mr. Rajesh Kumar, Mr. Ramesh Kumar, I call it Sasa, spell alike, sound alike patient. Anybody can get confused, and the nurses are pretty busy. So insist on safe practices all the time, which is safe for the nurse as well as for the patient. Thank you everyone for joining in the discussion. Fantastic. Let's move on, Swarupa.
Yes, ma'am.
Sorry, ma'am, I'm at trap. I have one question. If patient didn't say their name, then we can do one thing. We take the old document beside the patient and we check before going to give correct name in
That must,
patient.
correct. That must happen. The name asking should happen if the patient can converse and if they are conscious. They should be, because everybody knows their own name, no? So you can ask, kindly state your name. Don't ask Mr. Sharma, I'm going to give you insulin, or Mr. Rajesh Kumar, I'm going to. People don't pay much attention. What you're standing right beside them. It's better to ask them, can you please state your name? And then match UHID and name with that of the file, with that of the ID. It has to happen at the bedside. This is very important. So you can always go back and check whether this is happening, because when I was a CNO, everything was trained. But I've had nurses who will go and give the medicine because they have been looking after the patient for the last 5 days. So they know by heart, I have to give these two medicines at 10 o'clock, which is a wrong practice. Thank you for the question. Great. Let's
Ma'am,
move
can
on.
I share something here? Can I share something here?
Yes, because we have to
One
also
incident which
complete.
happened in our hospital.
Sorry?
Yeah, just one incident, because all are mobile tech now. See, even the patients are inside the mobile. So this incident really happened in our hospital. So I'm just trying to tell. The
Okay.
patient was in the mobile. The nurse rechecked the name. The patient was so busy. And after that, administering the medicine, it's our duty to have a verbal consent from the patient for medication. So the nurse said, okay, I'm going to give you insulin. Then that clicked. He pulled out his head from the mobile and asked, insulin? Why insulin? I'm not diabetic. So,
Okay.
ma'am, now mobile is taking everything, concentration and everything. So verbal consent from the patient may also help. Just to add, thank you.
Yes. Fantastic. Yes, that is where the patient education comes, Before we give anything to the patient, we have to, it's a very good practice to read out what you are going to give to the patient. Very good point, Blessy. Great. Swarupa,
Thank you.
let's
Thank
move
you.
on to
Thank
right
you so
drug.
much.
Thank you, ma'am.
Yes, we are moving on to the right drug. So here again, there is a clinical background scenario, which is 45-year-old female admitted with urinary tract infection, prescribed with injection ceftriaxone 1 gram IV BD. Patient had no known drug allergies. What had happened? Here again, during evening shift, nurse went to medication trolley, retrieved a vial labeled cefuroxime instead of ceftriaxone. Both vials were stored adjacent to each other, similar color packaging, similar name beginning with cef. So here again, as madam mentioned, it is again sound alike and spell alike medications. The nurse prepared and administered the drug, did not perform independent double check. Next day, infection markers not improving. During consultant review, medication chart cross-verified with drug administration record. Error identified as patient received ceftriaxone instead of ceftriaxone for 24 hours. What could have prevented this?
Question is being asked to all of you.
Again, here the first of all that the six rights is deviated. Number one, and the storage of the medication, the LASA drug, the look-alike and sound-alike medicine have not noticed and stored together. That is another mistake had happened. Again, every step like before giving, we did not identify with the verified with the prescription. The doctor what is written and what I have got it from the pharmacy, what I am going to administer. All those parameters are made into error.
Exactly. So that reminds us the nurse who is giving the medication is probably the last checkpoint for every patient.
Yes,
LASA
ma'am.
obviously is an administrative policy that you have to keep it separate. All those things we can by mistake they were together. But if the nurse had followed the safe practices, whatever that we are discussing, if she read them or if she read the medications the right way, tried to explain to the patient, then probably she could have, taken care of that error at that point of time. I think we should go to the next right. You can skip this right drug, Swarupa. Go to the next right because we may run short of this thing. Okay, we can discuss this. Okay.
And here, when we look at the safe, there is a checklist which we can prevent administration errors, which talks about safe reconstitution checklist. Here, the parameters we can look at, read the manufacturer's instructions, use only the recommended diluent, reconstitute to the correct final concentration. Always use a syringe to measure diluent, label the reconstituted vial, have the final concentration double checked, and affix standard dilution charts, no active reconstituted, and affix standard dilutions. These are the parameters when we look at. So maximum errors we can prevent based on this checklist. When we look at the right door, here there is a scenario which talks about 4-year-old child admitted with acute asthma, exacerbation. So here prescription injection hydrocortisone 25 mg IV start, which is written clearly. Hydrocortisone 100 mg per vial to be diluted and calculated appropriately. What happened here? Again, assigned nurse prepared the drug due to incorrect calculation. She administered 50 mg instead of 25 mg. No independent double check was done. Pediatric dose not verified with senior nurse. Here again, what could have prevented this is the question for the viewers. And more common wrong dose examples here, examples are insulin 10 units misread as 100 units, heparin 5,000 units miscalculated as 50,000 units, potassium infusion rate set incorrectly, morphine 1 mg misread as 10 mg, dopamine infusion prepared with wrong concentration. Video. A right time, always wrong time errors wherein a medication is given outside the predetermined interval from its scheduled time. Example, giving a blood thinner hours late, reducing effectiveness. To look at the example of right time, here injection streptokinase orders was written clearly in the ward, whereas supposed to be shift along with the indent from the pharmacy while shifting to the OT, but these nurse is done without reading the prescriptions clearly. The drug was administered at the ward side. It's supposed to be given in the intra procedure. Unexpectedly, the nurse gave, but again, there is no harm or hemorrhage to the patient. What could have prevented this? Here again,
Swarupa, just hold on for 1 second.
yes, ma'am.
Let the audience interact. So can you go back to the previous slide? The streptokinase slide there.
എന്റെ ഫോണിന്നാണ് ഇത്രയും നേരം കരഞ്ഞിരിക്കുന്നത്.
Hello? Yeah. Stay there. Okay, can we discuss quickly team, what could have done? This is actually, keep it in the kindness, please. Yeah, thank you. Yeah, tell us how this could have been prevented, or what could have made this happen.
Please participate, audience. Please answer.
Hello? Now everybody stop talking because it is not written how this
No,
could have
ma'am.
been prevented.
Ma'am,
No.
In this, the pre-operative checklist was not done correctly. If it would have been done correctly, the one who has shifted the patient and one who has received the patient could have caught the mistake here itself.
No.
That's why.
Understand, Blessy. The situation is the drug should have been carried, but the nurse gave the drug in the ward. How did she end up giving the medicine in the ward?
Ma'am,
Because it
the documentation of the medication when it has to be given may not have been mentioned in the file. And
No,
both the nurses
it is
also.
very clearly written to
Ma'am,
carry
she is
the drug.
assumed that medication I can give before shifting to OT
I like
without
the
checking
word.
the.
I like the word assume. Assumption is probably the most frequent culprit in errors, because our nurses
Yes,
will
ma'am.
say, I thought. What are you thinking? We are only supposed to execute the order. And other things, streptokinase, is it a high alert medication?
Yes.
How did she give without a double check?
That's the thing.
So even the in charge has not involved, right?
Yes,
So
ma'am.
usually I tell you what happens. Sometimes we make double checks, just a routine, a policy, because I have seen people, the staff nurse will say, Didi, I have to give insulin, double check. Didi will say, do, I will sign. This is the exact scenario that could be happening in all the wards. Now it is very important, because what policy have you written down? Like one hospital said that we double check all the medicines. Then I said, I don't believe you at all. It is not possible. It's impossible to double check every single order that is given in an hospital. So it's very important to write down, this is where you cannot give without a double check. And they must understand why we are insisting, because here patient was lucky, patient did not bleed. This patient could have blood in his brain, correct?
Yes, ma'am.
Then what would happen? Then it becomes a sentinel event. So storytelling is very important. So if something like this happens, we should not say, thank God nothing happened to the patient. Next time something will definitely happen. So that discussion has to happen. And many times our nurses are not able to see what could have really gone wrong with the patient if she or the patient was unlucky. Correct? So I think that discussion involving the shift in charge or the team leader is very important. Why the double check is not happening? What's the real reason? Is it because they are not able to come together? They are not giving priority, or they are only prioritizing, I will do the second signature? If I am the CNO, I will definitely ask, how did the team leader double sign the one, right? Okay, carry on.
when we look at the right route, here one more scenario which is talking about a 15-year-old female was admitted to the emergency department, came with the generalized urticaria and lip swelling, difficulty breathing. Here again, suspected anaphylaxis following IV antibiotic administration. The physician immediately ordered injection adrenaline 0.5 mg IM, which is 1:1000 concentration. So what happened here? The nurse on duty retrieved adrenaline ample, drew 0.5 ml into a syringe, administered it IV push through an existing cannula instead of IM injection. So here again, what immediate clinical outcome is It is went into the severe signs and symptoms, which is tachycardia, hypotension, arrhythmias, chest pain, and ICU transfer. Later, patient stabilized, anti-arrhythmic treatment, ICU monitoring for 24 hours. Fortunately, no permanent harm occurred. So, what could have prevented this? Anybody can explain the scenario? What went wrong here?
First of all, so before going to giving any medication, we check the documentation what doctor has written in the file patient, and then it is, as we know, this is the high risk medication, and other medication also we given before going to give, we check first what is the doses is written, right route, right patient, right dose is also important. So this will help to reduce the error medication.
No, what error here happened actually?
Ma'am, the
Maybe
he
the
the patient
Root.
He has given
route
wrong route.
route is route.
Wrong.
I think double
I
check can be prevent these kind of errors.
Yes, it is instead of IM, she gave an IV.
Yes.
So injection adrenal needs always it is a high
I
efficacy medication which is we use into the different events, emergency events.
Thank you for participation. Very good. We can go ahead now.
Yes,
The
ma'am.
next slide.
When we look at the few examples of common wrong route medications, potassium chloride IV push instead of infusion, oral syrup given via IV port, intrathecal vincristine instead of IV, insulin given IV instead of subcutaneous, tranexamic acid intrathecally instead of bupivacaine, causes fatal seizure. So always stay alert, double check is required. Right monitoring, again here an example, 72-year female admitted with atrial fibrillation, injection heparin infusion as per protocol with APTT monitoring every 6 hours. Infusion started correctly, dose calculated correctly, pump set correctly. What happened here? Again, the first APTT sample was due at 2 p.m. and lab sample was sent at late 4 p.m. Result critical high APTT value came at 6 p.m. The report was uploaded in the system. No alert was triggered. Nurse did not review lab results before continuing infusion. Heparin infusion continued overnight without dose adjustment. Next morning, patient developed hematuria, drop in hemoglobin, oozing from IV site. Repeat APTD showed dangerously elevated levels. Infusion stopped immediately. Protamine administered. Patient required blood transfusion and ICU monitoring. No permanent harm, but significant preventable bleeding event. So, what could have prevented this here
Ma'am,
in this
6 hourly
situation?
APT monitoring should be done.
Yes.
6 hourly APT
Reporting was
monitoring
not
should
done
be
in
done.
this case.
Very good answer, because these are the high risk drugs and which actually needs a monitoring so that it should not reach at its dangerous level. Very nicely answered. So nurses must know which are the drugs which needs a regularly or very strict monitoring the drug levels. Can we move next, Swarupa? Thank you for participation.
When we look at the right monitoring, the common monitoring errors, insulin infusion without hourly glucose monitoring, potassium infusion without cardiac monitoring, vancomycin without trough level monitoring, sedation infusion without RAS scoring, magnesium sulfate without reflex monitoring. So these are the levels which is mandatory to look for of all these medications. And wrong documentation leading to extra dose, which is again here a community acquired pneumonia. Prescription is written injection piperacillin, tazobactam 4.5 grams IV every 8 hourly, and it is TAD dose. Right documentation, what happened here is again 6 a.m. dose was administered by the night shift nurse. Due to heavy workload and multiple admissions, she didn't hand over, she forgot to document, and she didn't hand over orally at least the drug which is given. And no tick mark, no time entry. At 7:30 a.m. during shift handover, again the morning nurse is given at the 8 a.m. antibiotic. Later during consultation round, it was discovered that the patient had received 2 doses of within 2 hours. What could have prevented this?
Before administration, ma'am,
Yes,
hello.
yes, please.
Before giving the medication, she should ask once again to the during taking the handover. Then she should give.
Yes.
Patient may not
Moreover,
be that much aware now.
moreover, the
So which
drug
medication
chart,
is being given?
We should
drug
involve
chart,
the patient.
no, the drug chart also should be handover. While giving handover, they should show the medication.
Yes.
These are the medicines I have given. The proper handover of that is very important.
Very nice. Very
Yes,
nice. Fantastic. So nurse, when administering drugs or documenting drugs, they must be aware that each medicine is loaded with lot of side effects. So we have to take precautions. We have to document what will happen if the dose goes higher. It goes a double dose. So that is what the proper documentation is very, very important. Very nice answer. Next, we can move. Surupa.
Yes, ma'am. Preventing administration errors before preparing the drug. So verify the drug prescription, clear drug name, correct dose, route, frequency, signed and dated order. Clarify incomplete or unclear orders. Never interpret illegible handwriting. Confirm allergy status. Check indication. Does this drug make sense for this patient? So right patient, use two identifiers. Ask patient to state name. Do not use bed number as identifier. Check wristband before administration. Right drug, read label 3 times when picking up, while preparing, before administering. Watch for look-alike, sound-alike drugs. Check expiry date, verification.
Just to go back, Swarupa, just go back. Let me ask our people, all the people sitting here, do you think that our nurses, while administering, they really read label 3 times?
No, mom.
no.
They
No.
don't.
No.
No. So all the answer
No.
is so
No, ma'am.
how do we get our nurses to practice this? This is one of the most safest thing I have done in my entire life as a nurse. I have spent almost 16 years in critical care giving so many medicines, but then when the patient is unconscious also I'll be talking. So I don't know how do we encourage our nurses to do this? I'm sure they know. If you ask the theory question, they will say, yeah, I need to read it 3 times because this was taught in the nursing curriculum. So how do we get them to practice this? Any ideas? Any ideas? All the leaders sitting here, how can we get them to practice this? Because I am very sure all the things which is being done here on the left hand side, right patient, we are writing, ask the patient to state the name. Then we are saying that check wristband before administration, compare with the medication administration record. These are behaviors. Then read label 3 times. How do we get them to do this? There are nurse leaders here. If you are the CNO, what will you do to drive this behavior?
Ma'am, the person should understand that it is if I give a wrong medicine, what could have happened with my patient. That individual things they should understand. One that individually they will understand, they will not repeat and they will cross check with 3 times, ma'am. But they should, they know it's not like somebody force and they will do it. They themselves they have to think that they have to do it without that deviation. I will administer medication to my patient.
So
That they have to.
how can we drive? We are always saying they have to, but they don't
That,
do it.
Ma'am,
with
the only thing
Monitor,
that
they're
we can do
supposed
is
to
by
monitor.
observation.
Ma'am,
Like we do it, everyone will try to practice what is correct. So like for me, I always read 3 times because I made mistake because of it. So I made it a practice to read 3 times. When I'm teaching my students also, I read it 3 times. Then they are seeing it. If they learn from it, they grasp and they will follow the same. Observation and sensitizing them will work out, ma'am. Otherwise, they won't do it.
So
It's
one
not
you are
easy.
saying that
Ma'am,
we should role model what we should be doing. Okay. Yes,
I
Margaret.
can tell you the role model, madam. Manpower,
Okay.
can we increase the manpower before
I mean to say, if at all that many drugs are going to be given and that patient is ventilator, so giving the manpower, another assistant sister or somebody junior nurse, if you are giving to her, it can maybe provided, it can be reduce the
That is
cause of.
situational. That is situational, dear. It is not always manpower.
Yes.
Because
Yeah,
when
Ma'am,
you
I
are
one
giving
thing
disagree.
is
medicine,
empathy. If
I
they learn
Ma'am,
about the empathy,
Ma'am,
then they can do.
just a second. We'll take one by one. Yes, Margaret.
Ma'am, I want to say that in this situation, the patients who are conscious, I'm only talking about those who can read and write and are conscious patient. For them, when I go to the bedside, if it is me, and when I pick up the drug from the side locker or his wherever the medicine is kept, that's number one. I check the medicine at that time. Then I explain to the patient the purpose for which I come, and I involve him, and I say that. Sir, I'm going to give you this medicine. Can you help me identify this medication correctly and engage him in the medication administration? So he verifies it the second time for me. And then when I'm loading it or removing it from the strip or loading it from the vial, I read it once again. So that is my recommendation.
So that's a practice that we
yeah,
all do, you know. So I think people, the young nurses should see the seniors doing it. That's very important because when they come into the hospital, they will pick up the habits what the seniors are doing. It is very simple as that. Theory wise, they know. Blessy is telling she has taught them everything in the college. Fantastic. But when they go to hospital, they see that nobody is doing all that. They have been trained. Then what happens? Slowly they will start dropping the good habits that they learned. Both can happen. So I think what Margaret told, and that's what I used to practice. So if I am going to the patient bedside, I'll say, okay, can you
Hello.
please state your name? I will ask for the name. Just hang on. I will compare the wristband with the medication. Then I'll say, okay, Mr. Sharma, you are supposed to be getting injection ceftriaxone. So we got this injection here. This is being given for your fever. I'm sure you know that. Just give me a second. Let me just dilute this. You know, I am keeping the mar right at the side and the drug is there in my tray. I prepare that and just before giving also I can tell Mr. Sharma, here is your ceftriaxone, 500 milligram. I've got it right. You know, continuously speaking to the patient as Margaret told, wherever possible, engaging the patient, it becomes an opportunity for you to teach the patient also about the medication. Sometimes it may be saying, okay, Mr. Sharma, you have been getting this medication for a long time. You know, you are getting ecospirin. Would you like to tell me what is the action? Your education is also some dialogue has to happen because if we are quiet and silent when we are supposed to talk to patients, nothing is going to help us. Administratively, I have a suggestion. Administrative, you can do specific audit for these behaviors.
ma'am,
So,
ma'am,
just a second, Swarnalata. Listen and then you can comment. Okay. Specific audit. Observing the nurses. Are they reading the label 3 times? Are they talking to patient during the administration? That those things, you know, if you do it repeatedly, they will know this behavior is very important. It takes a little pain from the, you know, senior team, but investing in that will definitely help. Otherwise, we will not have a pie that has largest, you know, administration errors. We can prevent that. Yes, Swarna.
yes, ma'am. The same thing I would like to emphasize, ma'am, regarding this audit. We used to do the practice check related to the medication administration. So we have the medication nurses in our system. So we used to give that at least 10 nurses they can go for the practice check how they are going to give the medication. So that is the one part you already explained, ma'am. Yes.
Okay, great. I think
Hello.
we know we should be able to break down our
Can you
audits.
hear me?
Don't always think the NABH wants this, so I will do that audit. You know, that's not the objective here. Whatever is required to drive the safe practices, you can drive it because you when you audit, if you find a nurse doing the right thing, please give the person appreciation, thumbs up, and recognition. So that is leadership. That is very important. Otherwise, it's very difficult to say that junior staff should concentrate. Believe me, please don't use the word junior staff. Huh? I have seen the senior staffs doing the same mistake. It is just that, they were lucky they did not make the mistake. So it is not always juniors. I would always say the seniors have to show the way and lead the way. That's very important. Yes. Okay, let's move on.
Adding on to that, adding on to that previous slide, ma'am, actually it should be a habitual always as soon as they pick up the drug. So they should read aloud to the other person at the time of giving and loading. So this is again which comes from person habitual. So this we have to empower them to read it mandatorily. And to look at the right dose, calculate carefully, use correct dilution, double check high alert drugs. Pediatric and insulin doses require extra caution. Right route, confirm prescribed route, check compatibility, ensure correct dilution for route, never change route without order. Right time, check last dose given, avoid duplicate dosing, follow hospital time window policy, coordinate with meals. Examples, insulin and oral drugs. Write documentation, document immediately after administration, record timely, never pre-sign. If omitted, document reason. Right monitoring, monitor required parameters, BP like example, antihypertensives, blood sugar, insulin, APPP, heparin, creatinine, nephrotoxic drugs. Check lab results actively, escalate abnormal findings.
Can you go back, Swarupa? Can you go back, please?
Yes, ma'am.
Let's ask the team here, what are the common errors that we see when it comes to right documentation and right monitoring? Please share
Ma'am,
your kids, yeah.
Ma'am, for the documentation in our organization, many times sister used to give the medication but forgot to document at that time. After giving, means after 1 hour or after half an hour, they used to come and document. So this is the means common mistake they used to do. On the time of administrating, that time they don't document, but after half an hour, after 15 minutes, they used to come and document. So we mainly face during our audit this problem, ma'am.
Yes, they will not carry, ma'am, the file they will not carry near to the patient along with the drugs. And immediately after giving the medication, they will not document. And whenever they're documenting also, that is like 8:15, 8:20, they will not document. 8 a.m., 7 a.m., 6 a.m. The round figure they will document, ma'am.
I think these
Yes,
are
ma'am.
very important habits that needs to be corrected. Again, it is our responsibility that it has to be a never behavior. When they come, you should say, never administer medicine without a medication administration record in your hand, except in life saving situations, right? It is a never habit. So it is very important to inculcate. There is an idea called always behaviors and never behaviors. So you state there are 5 behaviors which are always and what is never. That means there is no discussion. If a nurse gives medicine without the medication administration record, that means it's a never behavior. There is no explanation asked. The person has to be, you have to tell this to them before itself. This is the way that this we are going to function. You cannot give medicine without MAR. Very important. And you have to sign immediately, no pre-sign, These are some mandatory thing that we should be able to put in. So because this habit, the nurses, they do not take it to the bedside, they do not do this. This is our excuse, our leaders, I would say. So we need to insist that the right behavior happens. And it is very important because you can do double medications, you have not signed it, somebody else will come and give that medicine. And so all of you are aware, whatever you told, that is also the truth. I understand that. There are some comments coming. I will be reading those comments in a short while. Let's talk about right monitoring. Do you have some examples where the nurses were not able to monitor the patient and then something happened to the patient?
Yes, ma'am. After giving the BP medications and they are not monitoring the BP. And before giving the medication, they are not checking the how much the patient BP. And it is the time 8 o'clock, so I have to give the BP medication.
Without checking, they are giving the BP medication and it is leading to hypotension later.
So, fantastic example. How do we sensitize this? So, I have this thing in my head that when you are training nurses, do you actually do scenarios to sensitize, or you just simply discuss? So, whether it is new nurses, young nurses, this webinar is very nice. We are talking, but imagine that you are seeing a actual scenario wherein a nurse is giving antihypertensive medicine to a patient without checking the BP, and then the BP drops, and then the patient is going to ICU. If you create a scenario, then ask them that why did this patient go to ICU? Probably that scenario will stay with them for longer time than just looking at a slide. So that is what I am saying. Use the simulation methodology around all safe practices. Probably that will stick with them longer. And believe me, I'll give you another easy way. If you do one time scenario, you can record that. You can show that to any number of nurses or any number of times. You can ask them what went wrong. So these kind of things, it is very difficult to repeat in the hospitals. So we can use this concept and convert this into self-learning for many nurses at the same time. So technology is, coming to us. We should be smart enough to use the technology also. Okay, thank you. Let's move on. We have got some good comments in the comment box, so we need to go to that.
Uh, Moving on to the next slide, the critical thinking safety points. If in doubt, stop. Ask the senior doctor or pharmacist. Do not assume. Do not rush under pressure. Speak up if something feels wrong. High alert medications require extra care. Example, insulin, heparin, potassium, magnesium sulfate, chemotherapy, and inotropes. So here again, never miss this. Bed is not the patient, and check expiry dates, match drug with indication, separate laser drugs in trolley, route changes risk drastically. Patient education, a powerful safety tool, as it is important for a patient to know about their medications and their efficacy and the dosage of the medication and the timings of the medication. So these are all the things as a nurse we need to explain them. The name of the drug and why it is given, dose and timing, possible side effects, when to report symptoms, importance of the compliance.
The patient is in receiving rifampicin for a anti-cox treatment. So we should explain to the patient there will be change in the urine color. So there may be fear, anxiety, what is happening. If the patient is well informed, so there will be a more of acceptance. This is because happening which drugs I am receiving. So that patient must educate. We must educate our patients the drug they are getting, especially the names. Many I have seen many of the patients, especially diabetes and hypertension. Once I simply randomly checked, no patient, many of the patients, they don't know their name of the diabetic and hypertension drugs which they are taking for the years together. You all can check this with the patients. So we must educate the patient. Next, Surupa.
Next slide, ma'am.
Yeah.
The safety impact, an informed patient becomes an additional safety check. When patients know their insulin dose, their anticoagulant precautions, their allergy status, they can prevent errors before harm occurs. Next one. To summarize, what all we have gone through all these slides. So nurse medication safety, never miss list. Know the patient, and here again bed number is not the patient. To know about the confirm full name, age, and other details. Verify the prescription, and if unclear, clarify before preparing. Next one. Check high alert medications, and these drugs can harm quickly. Example, insulin, heparin, potassium, all high alert medications. Next one. Keep communication open. Assumption leads to errors. Confirm during handover last dose time and mention pending labs and escalate the abnormal results. Clarify verbal orders with readback. Document immediately. If not documented, it is assumed not given. And according to the records, exact time and dose route, document patient response and refusal, and never pre-sign. Correct system issues you identify. Safety is everyone's responsibility. Separate laser drugs, report unsafe storage, highlight unclear labeling, escalate repeated process gaps, speak up without fear. Know the indication, why is this drug prescribed for? And if you don't know why it is given, pause and clarify. Know the dose range. If the dose feels unusual, recheck. And always, it is an adult or a pediatric dose, it is mandatory to recheck. And the scenarios, whether it is a disorders or a disease conditions. Know the route and dilutions. Wrong dilution changes safety drastically. Know the timing before food or after food. Timing affects effectiveness of the medications. Know the side effects. What are the common side effects and anticipate before harm occurs. Know the monitoring parameters, which vitals must be checked. Example, high alert medications, heparin, insulin, vancomycin, inotropes. Monitoring is part of administration. Know the high alert status. High alert drugs need high attention. Is this a high alert medication or independent double check and need pump-based administration? Here again, there is a golden principle which talks about do not give a drug you do not understand. Patient education, yes, we have mentioned that it is mandatory, is not an extra work, it is preventive safety and it is a responsibility as a nurse. Patients who understands their treatment can prevent errors. They become additional safety checks. Education builds a safety partnership between patient and nurse. Patient education is preventive safety.
So that is what WHO had emphasized on patient engagement. So that is the reason where patient can participate in their own care and harms can be prevented to their own health.
And here, these are the references which is collected the sample size. Thank you.
Everyone for attending. Very really thank you so much. I would like to give an example over here. Whenever you are in especially area, you also observe the patient at the same time. I have seen one patient. The doctor was so much anxious and annoyed at me. The BP was continuously dropping down, and patient was quietly sitting, nicely eating breakfast. So I thought, what happened? Why this doctor is continuously behind me? Start the IV fluid. I was looking after three patients in ICU. Start IV fluid immediately. You start. He was annoying me so much, talking loudly. I got so much angry. And by the time patient, I am looking, patient was very stable, eating breakfast and everything. So by the time, after some time, the patient's consultant came there, and then he told me like, "Na sister, see, whenever even if patient is stable, even if you see there's a BP is drop, don't get panic. You observe the patient." So I look at the doctor. See, you were very much panic. So these are the kind of situations. Sometimes we have to observe the patient very. Yeah.
Patients are not treated by numbers.
Yes, ma'am.
Patients are treated by patient, by observing the patient, right? So I'm going to, because I am aware of the time, 8:31, I'm going to